Hello, everyone, and welcome to the first webinar of 2024, Developing a Sustainable, Impactful International Keratoplasty Skills Transfer Program. Here we have Dr. Anthony Aldave of the Jules Stein Eye Institute. A few quick housekeeping notes before we get started. This webinar, all of our webinars are recorded and available on demand on our YouTube channel. Please keep an eye on your inboxes for more webinars coming up throughout the year. All participants will be muted throughout the duration of the webinar, but please do ask questions. You can enter them into the Q&A panel at the bottom of your screen on your computer or on your phone. The questions will be answered at the conclusion of the talk. And so now on to a brief introduction of tonight's speaker. Dr. Aldave is a professor of ophthalmology at Jules Stein Eye Institute in Los Angeles. He's the Walton Lee Chair in Cornea and Uveitis, co-chief of the Cornea and Uveitis Division, and director of the Cornea Fellowship Program at Jules Stein. Dr. Aldave has received numerous honors and awards throughout his career, and in addition to his busy clinical practice, he directs the Corneal Genetics Laboratory at the Stein Eye Institute and founded Visionaries International, a nonprofit focused on reducing the global burden of corneal blindness. He's authored over 170 peer-reviewed scientific publications, given countless presentations at local, national, and international meetings, and serves as a scientific reviewer for 20 ophthalmology and genetics journals. And so now I will hand the floor over to you, Dr. Aldave.
Thank you again for the invitation to participate in this webinar and to allow me to talk about something in which I have significant interest, and that is trying to address the global burden of corneal blindness through training of colleagues in different countries. I want to thank Eversight not only for the chance to give this presentation, but also for the support of many of our efforts as far as supplying corneal tissue, as far as materials, and even the promise, which I'm going to hold mic to help train surgeons in other countries to prepare tissue for endothelial keratoplasty. By way of disclosure, I am not paid to give this talk. These are my disclosures, none of which I think is relevant to this presentation. So I'm hoping that those of you who are listening have in your mind some questions that are similar to those that I have on this slide, because these are the questions that I'm going to address in this presentation. The first one is, if I'm interested in getting involved in global ophthalmology, how do I determine where I can make a difference? The second question is, how do I determine what I can offer? How can I figure out what I can contribute? The third question that I will address is, how do I determine who I should work with? Is some organization that I can pair up with? Can I start my own program? How does one get involved? Fourth, and very important, is how do I ensure that what I'm doing is sustainable, that's going to have some lasting effect? And then finally, how do I make sure that what I'm doing is impactful, that it's worth the time and the effort that I'm going to expend as far as outcomes? And the outcomes be, of course, training surgeons and or helping those with corneal blindness internationally see better. So let's talk about the first question, which is, how do I determine where I can contribute? If you're talking about where the burden of visual impairment and blindness due to corneal disease is the greatest, this map shows that worldwide, there's about 5 million individuals who meet the definition of corneal blindness or moderate to severe visual impairment, that MSVI, which is 20/60 or worse vision. Of those 5 million, 70% or 3.5 million live in Asia. As you see on the map, East Asia and Southeast Asia. So because of this, and because I live on the West Coast, I have focused most of my energy and my time and my efforts in Asia. But I certainly think everybody would recognize that there's corneal blindness globally, less in North America and in Europe. There is a fair amount in sub-Saharan Africa, but if we're looking at where we're going to be putting our efforts, we have to make sure, of course, it's an area where there is access to corneal tissue. And unfortunately, in many parts of the world, there is a lot of corneal blindness, but without an access to corneal tissue, thus making training of keratoplasty not as effective. So Asia, I guess, depending on how you count, somewhere around 23, 24 countries. And of course, it varies significantly, not only in GDP and the languages, but also the population prevalence of visual impairment and blindness due to corneal disease. Now, the country that has the highest population prevalence is India, with about 0.9% of the population, almost 1 out of 100 people, meeting the definition of moderate severe visual impairment or blindness due to corneal disease. Interestingly, the country that has the lowest population prevalence is right next door, Sri Lanka, at 0.5%. So about, my math's right, about 1/16 the population prevalence of that in India. Why such a discrepancy? Well, primarily because Sri Lanka has 2 eye banks, one of which was established probably 1960s, 1970s, a long time ago, and shows the impact that local recovery of corneal tissue can have on the prevalence of corneal disease and corneal blindness in a population. Now, if you're going to be getting involved in addressing corneal blindness, let's say through working with colleagues in these countries, you also should be aware of how many ophthalmologists there are to work with. In Asia, you see it ranges significantly from 3 per million in Cambodia to over 100 per million in Japan. So we had a cornea fellow last year from Cambodia. She, I believe, is one of only 2 or 3 corneal trained specialists in the entire country. In Cambodia, I think, is around 16 million people. So we felt guilty pulling her away from Cambodia to come here for her training, but very satisfied knowing that going back, she has the potential to make a big impact, given the responsibility she has for about what would be 5 million people. If you're wondering how many ophthalmologists per million population in the United States, it's around 60 per million. So the US would be somewhere between South Korea and Taiwan. So the bottom line is there's an issue as far as the number of ophthalmologists per million population, which can then be an issue, of course, if you're looking to try to train ophthalmologists in the country of interest in different forms of keratoplasty. So the second question is, how do I determine what I can contribute? And that's a good question. I want to give you an example here. This is from an article we published in Cornea a few years ago on corneal blindness in Asia. We looked at the indications for keratoplasty in a number of different countries throughout Asia, as you see listed here, and then the types of keratoplasties that were performed. And if you look at the Philippines, and this data is from about a little over 10 years ago, you'll note that at that time, 38% of the transplants were being performed for pseudophakic bullous keratopathy. However, only 2% of the transplants were endothelial keratoplasties. You say, well, maybe EK really wasn't around in Asia at that time. Well, not necessarily the case. Same time period in Japan, same percentage of patients having keratoplasty for pseudophakic bullous keratopathy, 38%. But in Japan, 43% of the keratoplasties were EK. So pretty much everybody in Japan who had isolated endothelial dysfunction was receiving an EK, whereas those in the Philippines were getting a PK because surgeons weren't doing endothelial keratoplasty. So thus an opportunity for somebody who knows how to do EK and would like to share that with their colleagues. So we conducted a DSAC skills transfer course in Manila. This was 10 years ago this month. Depicted here sitting or standing behind me in this image on the right is Magita Padilla, a friend and colleague who started the eye bank in Manila. And this DSAC course coincided with the eye bank in Manila preparing and providing tissues for DSAC surgery to Filipino surgeons. And since that time, the number of DSAC cases has increased significantly. Now, EK, though, is not going to solve the majority of the problems with corneal blindness in Asia. Going back to that same article, we looked at the causes of moderate severe visual impairment and blindness due to corneal disease in different Asian countries. only two, China and India, had enough publications to really get a good answer. And in both countries, keratitis, this is infectious keratitis, was the leading cause of vision impairment due to corneal disease. Trauma, second most common in both countries. So what that means is that if you're going to be addressing corneal blindness in these countries, that teaching penetrating keratoplasty, or DOLC, would probably be most useful. Looking at Vietnam, this is an article we published a few years ago from an eye hospital, Vietnam National Eye Hospital in Hanoi, and looking at corneal indications for corneal transplantation at that hospital over this 11-year period. And you'll note that the leading cause, a leading indication again here, is infectious keratitis. So India and in China, leading cause of corneal loss of corneal clarity, if you will, is infectious keratitis. And in Vietnam, the primary indication for keratoplasty is infectious keratitis. You'll note that the second most common is corneal scarring. What are these corneal scars from? Well, if you look, you see here that 82% from prior infectious keratitis. So clearly in Vietnam is the same stories we see in India and China, that infectious keratitis and scarring that follows is the primary indication for keratoplasty, the primary cause of corneal visual impairment, and again, thus the need for PK and DOLC in these countries. Now, how is it managed? Well, at the same eye hospital, this is a paper that we, again, published a few years ago. We looked at treatments for infectious keratitis at the hospital. These are all the different treatments here, and you'll note that 7% of these eyes required evisceration. And I think for all of us who practice domestically, to think that, 1 out of 12 people who comes in with a corneal ulcer has to have their eye eviscerated is hard to fathom. But this is because there's no corneal tissue there. And so if a patient develops a corneal perforation that's too large to glue or use amniotic membrane as they have access to, those eyes have to be removed. Again, this is at the hospital in Hanoi. Unfortunately, it's the same thing in southern Vietnam, looking at outcomes infectious keratitis, where it's a very similar percentage. In Hanoi, it was 7%. In Ho Chi Minh City, it's 8% of eyes are eviscerated or nucleated for infectious keratitis. Again, due to the fact that these patients develop corneal perforations, which cannot be glued, and the eye can't be closed, so thus the eye is removed. This creates another opportunity then for somebody who would like to make an impact. In this case, once they became aware of this, was able to provide this long-term preserved corneal tissue, in this case provided by CareLink and SightLife, but there's many companies who provide long-term preserved corneal tissue, which can be kept on a shelf up to 2 years in most cases and be readily available to serve, as you see in the photograph here, as a patch graft for patients who develop corneal perforation. Obviously, this can salvage the eye, and then that patient can have subsequently a optical keratoplasty if needed to restore vision. And so there's a lot of things that we have available here in the US that are not available internationally, but can be used to address a significant need internationally. Third question, how do I determine with whom I should work? There are a lot of organizations that do great work internationally. I'm not going to go into a big discussion of all of them now. I think you're probably familiar with Orbis in the Himalayan Cataract Project and others. I'm just going to give you the perspective of somebody who wanted to go out on their own and try to connect with colleagues. This is a picture from Eversight Eye Hospital. This is now hard to believe, 16 years ago. I had met many of the people there as a cornea fellow when I was at Proctor about 7 years prior to this. And I asked them if they'd be interested in learning how to do the Boston keraprosthesis. So in the image you see to my left is Dr. Srinivasan, the former head of the cornea service at Erevan in Madurai. He said, sure. And so I went there and we had about a week to 10-day course on the Boston keraprosthesis. And they then began performing it at that time. We also took the Boston keraprosthesis to Madurai and to our lab, a company that is associated with Erevan. You may be familiar. They make IOLs, sutures, viscoelastics, et cetera. And they reverse engineered the Boston keraprosthesis and then began marketing it about a year or two later. And it's been available in India for a fraction of the cost of the Boston keraprosthesis for the last 10 or 12 years or so. So that was a case where I went to a big academic center with which I had a pre-existing connection. Connections can also be made, for example, at meetings. And so I many times go to the All India meeting. It moves between different cities in India, give a course often on DMEC surgery or on keraprostheses or whatever. And typically what you find is people who attend are those who are performing the surgery and would like to learn more about different techniques, et cetera, or people who want to start performing the surgery. And if they know that you are interested in helping spread knowledge regarding keratoplasty, then that's a great way to connect with colleagues globally and find out who's interested in learning and make those connections. Then the result in you're being able to help somebody incorporate these techniques in their armamentarium. One other option is to join forces with a professional organization. This, as you see on the podium in this picture, it says CSI. This is Cornea Surgery Interest Group of Thailand. This is a group that is made up of, I think, virtually all corneal surgeons in Thailand. This was the first symposium that they organized, 2015, in which I and Samar Basak, I think Elmer too, came and did a DSAC workshop. And that was actually, it was a great course, and many of the surgeons began performing DSAC after that. This is a horrible picture of me. It doesn't even look like me here. But this was just a month ago. We went back and conducted the first Boston keraprosthesis workshop in Thailand, as you can see on the slide. And again, organized by the same group. Having local organization is key because they really were able to, as you can see in this photo, have a great turnout. These are all corneal surgeons from Thailand. I think it's probably the majority of them from Thailand. They're all very young, as you can see. And also they were able to get support from local companies to pay for the AV, the meals, et cetera. And so I think if you can partner with a professional organization in whatever country it is you're interested in working, that is a great way to really make sure that you're reaching all of the surgeons in that country who may be interested and help with a course, end up with a course like this, which is extremely well organized. And I think the more organized, the better the audiovisual, et cetera. I think the greater chance you're going to achieve the objectives of the skills transfer course. So the next question is, how do I ensure that the work that I do is sustainable? And I want to touch on two aspects of this. One is funding, and the second is donor cornea supply, because without donor corneal tissue, it's hard to teach keratoplasty surgery, obviously. And we'll talk a little bit about using imported tissue versus locally recovered tissue. This is a screenshot from our foundation's website that I appreciate Mike's mentioning, Visionaries International. The quote there, as you see on the slide, is a summary of what we do, which is we teach our colleagues both basic and advanced forms of corneal transplant surgery. Would not be possible. This was founded in 2008, so this is our 16th year. Would not be possible to do what we've done without having a 501c3. You really have to have one to be able to apply to various companies for grants, for gifts in kind, and also to appeal for donations from grateful patients, et cetera. And so if anybody who's listening is really serious about getting involved in global ophthalmology, I would say that you need to really think seriously about either joining with an NGO or looking at starting your own 501c3 nonprofit. Because without that, I think it'd be very difficult to build a sustainable program. Now, what about the corneas that you're going to be using? The two options, of course, are either to bring corneas with you if you go to X location or have them sent there from a different country, or to recover corneas locally. And many of you are probably aware of the fact that corneal recovery locally does not meet the needs, but only in a very few countries. So in almost every situation where you're looking at a situation where you have corneal blindness that is not being met with the rate of corneal transplantation, it's going to be a country where the rate of local recovery is not enough to meet that need. So if you look at the data from the EBA statistical report from 2022, I don't know if we have the data yet from 2023. I don't think it's come out yet. You notice that there was about 70,000 corneas distributed, actually 79,000 corneas distributed for transplantation by U.S. eye banks. Of those, 50,000 were transplanted domestically, and about 22,000 were distributed internationally. 22,000 is a pretty good number of corneas, but when you look at, I remember going back to that slide about 5 million corneal blind globally, it's just, unfortunately, a drop in the bucket. But at least there are eye banks, such as Eversight, who generously provide tissue to surgeons to use for international patients. And it's not an onerous process. This is the gratis tissue report. You see, this is the one I filled out just a month ago to request corneal tissue for Thailand. And Mike, I think you could refresh my memory. I think you provided like 24 corneas for the wet lab and maybe about 4 to 6 for transplantation. And so quite a haul of corneas, almost 30 corneas that I took, all courtesy of Eversight, for which I am very grateful. So many eye banks in the US will provide you with corneal tissue. You just need to give them enough advance notice to be able to try to meet your request. As far as I know, focusing on Asia, there's only 1 or 2 eye banks right now that are distributing tissue outside of the country. The Nepal Eye Bank is one of them. They actually have good corneal tissue. I use them a lot when I'm in Asia to try to ensure that there's corneal tissue available. I usually will bring tissue with me and have tissue sent from Nepal. Sort of a belt and suspenders approach to make sure the pants stay up. A PK tissue from the Nepal Eye Bank costs $400. Pre-cut tissue for DSEC, $600. Sounds, and it is quite inexpensive. Unfortunately, for many people who need these tissues in Asia, that's too much. But at least for some, it's affordable, and at least for a foundation like ours, it's something that we can deal with, being able to purchase and then provide to patients there. The other eye bank that I believe is now distributing again, as I mentioned, in Sri Lanka. They had stopped exporting, as far as I know, during the economic crisis, but I was told just a couple of weeks ago that they are once again exporting tissues outside of Sri Lanka. If you look across Asian countries, as you see here on this slide, there's only 4 of them in which the rate of corneal procurement exceeds the rate of corneal transplantation, meaning that would imply they'd have some corneas available for exportation. And those are India, Nepal, Philippines, and Sri Lanka. So these would be countries we think, okay, well, maybe these are countries where I might want to work because there's some corneal tissues available there. Well, India does not export tissue. I think it's not allowed at this time. So that doesn't work. China does not allow importation of tissue. And so even if there's a huge need, as there is, for additional keratoplasties being performed in China, if there's not much local recovery and you can't bring tissue in, that's a bit of a pickle. So the only 3, I think, in Asia, eye banks that have the ability to export are the ones in Nepal, Sri Lanka, and the Philippines. And I don't know if the Philippines is exporting much now, but hopefully they will be able to again in the near future. And then let's talk a little bit about how do I ensure that what I'm doing is impactful. I want to focus on how do you develop an effective skills transfer model? I'll present to you kind of the model that we follow, which has evolved over 16 years and now almost 70 skills transfer courses performed. But others have different models, obviously. It's really important to commit necessary time, effort, and resources to build relationships with these doctors in different countries. Cannot emphasize that enough. Your being there is extremely disruptive to their schedules. Imagine if somebody came to your hospital, your practice, and stayed for a week and totally rearranged your schedule, and you had to have all these patients come in on a certain day. Somebody had to contact them all to be screened. There's language barriers. This person has dietary restrictions, etc. It's really disruptive. And so if you can develop friendships with local surgeons and show them that your presence is a plus, disruptive, but still there's something to be gained, and that you are sincerely committed not to post what you're doing on Instagram for people to admire you, but because you really want to help them, then you'll be embraced, and then you'll be welcomed back time and time again. The last thing I want to talk about in this talk is evaluating the outcomes. How do we measure the outcomes of our efforts? What are the appropriate metrics? So how do we develop an effective skills transfer model? Well, what we've evolved to over, like I said, the last 16 years is we typically have two cornea faculty, maybe myself and a colleague such as Roberto Pineda, could be Elmer Tube, who I've worked with a lot, Satish Srinivasan, Sophie Deng, many people I've had the pleasure of, Samar Basak, doing skills transfer courses with. Having one person is a little too much as far as giving the lectures, running the wet labs, doing live surgery, proctoring surgery, especially benefit from having more faculty when it comes to you assisting the local surgeons. If there's only one of you, that really limits what you can do in a certain skills transfer course. Patient screening prior to arrival. It is essential that you know who you're going to see before you get there. Because if you get there and you don't know who you're going to see, it's going to be chaos. It's already chaos many times when you get somewhere because there's so many patients. But at least if you've pre-screened them, you know their history, you've seen the images, you know who may be a good candidate for DMAC, and you know what to look for in those patients. Patient screening on site is always the first day, and usually will take all day. And we'll see anywhere from, in Thailand, we only looked at maybe 10 patients because we're only looking to operate on 2 during the K-Pro course, versus sometimes we'll see 100 or more in a day when we're trying to determine who's appropriate candidate for a PK or a DULC. The second day is usually lectures that are in the morning. It's very helpful if the slides can be translated into local language. That means you have to get your talks done early and send them to somebody who can translate them for you, but that can be very helpful. We have had simultaneous translation also during a number of our courses, which can be very, very helpful. That's usually followed on the second or third day by a demonstration surgery by the visiting faculty. So I or one of the other course faculty will do a surgery. It's usually watched by some in the operating room, but usually broadcast to an auditorium, for example, where people will be watching it, and usually we'll have a mic. So I can speak, and then they'll have a microphone in the audience so they can ask me questions. And that having that technology really facilitates a good exchange, and again, I think most effective transfer of information. The live surgery is usually then followed by a wet lab for the trainees. Not everybody who wants to be in the wet lab can necessarily. So I think at the course we did last month, we had maybe 80 people, maybe 100, I think, in the audience listening to the lectures and watching the demonstration surgery. But the wet lab was, I think, more like 20 individuals. And then there's the proctored surgery by the host faculty. And that's, I think, where really people learn the skills the best, is by having somebody with them in their operating room, with their nursing staff, et cetera, do the surgery. So this is just a screenshot of our Google Drive. You can see this is Ho Chi Minh City Eye Hospital mission trips. And these are just various folders where we have the patients in these spreadsheets. If you go back, and you'll show you a slide a little bit later, it shows you how many times I've been to this eye hospital. It's imperative to keep track of who's who. If you're doing corneal transplants, as you all know, these patients remain at risk for complications for life. So you really have to be following your outcomes to make sure that you're doing more good than harm. You know, if all of your DMACs are detaching or your DSECs are getting interface infections, you need to be aware of it. You need to address it. Nothing is left to chance. You see here, this is an instrument and supply list for both the wet lab and the OR for the course that we conducted last month. You say, is it really, do you have to get down to this nitty-gritty detail? Yes. You need to know exactly how many needles and cannulas, et cetera, that they have, Teflon blocks. And if something is not available locally, either the local surgeons need to obtain it, or you need to bring it with you and leave it there. There's no sense in bringing in your fancy MST microsurgical instruments and then using them for Decimate stripping and capsulorhexis and then taking them with you. So whatever instruments are used during the surgery that people are watching, they need to have access to those instruments after you leave. One very short, quick anecdote about what happens if this isn't done. I was in Mexico a couple of months ago for a meeting. A good friend, Boris Malugian, came from Moscow to do live surgery. He had asked if all the necessary supplies and equipment were available locally. They said yes. So he did not bring anything with him. They assumed, since it's Boris Malugian, he'd be bringing a Malugian ring with him. So they gave him a small pupil cataract case to do. And when Boris asked during live surgery for the ring, there was no Malugian ring. There were no hooks. And so he really struggled during that case, although thankfully he's a great surgeon. But obviously it was difficult because of that miscommunication. And so I think that is why I like to have these sheets like this, just to make sure that everything that I feel like I'm going to need and the local surgeon is going to need to make these surgeries successful is going to be available. Here is the one of the waiting rooms at the Ho Chi Minh City Eye Hospital. These are patients waiting to be seen in one of the general eye clinics. This is on, I think, the first floor. I think that's what Lao 1 on that post means. So you get the idea. It's a lot of people, a lot of people. And so you really have to, like I said, do as much as you can before the trip to know who you're going to see, to ask, let's see these 40 people or whatnot, because these look like they're the best candidates, and then try to make things as systematic as possible. The hospital in Ho Chi Minh City does a great job. I think this is really the model that all skills transfer courses should follow. You'll notice that there's a PowerPoint slide in the background here. So a resident physician will present the case just like during a grand rounds, present the patient's case, and then they'll see, as you see on the slide there, have a proposed treatment. You'll see me on the slide on the image on the left and my colleague Simon Fung on the right. We will then examine the patient at a slit lamp that's hooked up to that monitor so everybody can see us while we're examining the patient. You'll see we both have microphones. So we're discussing what we're looking for in the pre-op evaluation of these patients who are candidates for DMEC or DSEC surgery. And this setup, I think, really gives a lot of educational value for the trainees at the hospital. And having those PowerPoints up there, it makes me immediately remember exactly what the history is. And so I think this is a very effective way to teach the pre-op evaluation and patient selection for different types of keratoplasty. After the patient screening is performed, I mentioned either on the second or third day, then I give the didactic lectures. This is a talk I gave in China a few years ago on DMAC surgery. Again, many times these lectures are going to be simultaneously translated and or slides in the local language to make sure everybody understands what you're trying to convey. After that, there's the live surgery. And I would say for all of you interested in global ophthalmology, if you're interested in skills transfer, you have to really be honest with yourself and say, am I comfortable doing this surgery in my sleep? Because you will be doing it in your sleep in a few of these countries. You'll be jet lagged. These are long days. You may not, feel 100% healthy. But if you've done, these surgeries time and time again, even in an unfamiliar environment, you can make it happen. Obviously, you're going to have nerves because you're in a different location. You're not in your operating room. You're not able to communicate often with the nurses without a translator. But as long as you keep in mind that you've done this more than the other people who are watching, that gives you a little bit of confidence, thinking if you screw something up, they may not even know it because I'm not sure exactly what each step should look like. So, but anyway, so the live surgeries are performed. I try to operate as little as possible. If I'm going back to a place like Vietnam, for example, where we've done DMAC surgery for a few trips, I don't do any surgeries myself. There's no need for that. The focus is on the local surgeons building their skill set. The next day in the skill transfer course is the wet lab. And here we see a trainee looking through the microscope. This is with the glasses, just testing the microscope. That's Dr. Samar Basak. This is at Aravind in Pondicherry. So we pair up the trainee surgeon and the faculty in the wet lab and make sure that the trainee learns Dr. Basak's way of doing DSEC, for example. So then the next day, same two surgeons, now in the operating room, but now we see that they're actually operating on a real live patient. So the wet lab is really critical to make sure that the trainee understands how the faculty wants the surgery to be performed. Because it may be a little bit different than what the surgeon who did the demonstration surgery, in this case me, did. But having that consistency from the wet lab to the OR, I think, really helps. A couple of other points I want to make. This is a colleague here, Dr. Fang with the glasses, who's this is in Hanoi, who's our ophthalmic anesthesiologist at the Stein Institute. I noticed early on that a lot of these countries that they don't do a lot of keratoplasties, and so they don't do general cases very much. So when we need to do general, a lot of times anesthesia is not comfortable doing it, or patients may waken during the surgery. Or if you're doing a block, they may not do retrobulbar blocks. They'll do peribulbar blocks, which I think is suboptimal for penetrating keratoplasty cases. So Dr. Fang has come with us on a number of these trips to really focus on the ophthalmic anesthesiologists and teach them about the ophthalmic anesthesia, which has been, I think, really very fruitful as far as increasing the success and decreasing the risks associated with keratoplasty surgery at that hospital, the other hospital where he's been. One other point I'd like to make is the importance of involving trainees. For those of you who are listening who are in academic centers or who may be in private practice, but you may have access to trainees if you're a volunteer clinical faculty member somewhere. My interest in international ophthalmology began when I was a fellow at the Proctor Foundation, and my trip to Erevan as a fellow just really awakened in me an interest in being involved in global ophthalmology. And I really like our trainees to have that same opportunity. So this slide, as you see, shows the various UCLA medical students, Stein Institute residents and fellows who've accompanied me on most of these skills transfer courses since 2012. So having the trainees with you it's a lot of fun. Because I think they really enjoy it. I had Erica Ellis with me, one of our residents in Bangkok last month. What is their role? Well, you see in the upper left, one of our former fellows assisting me in demonstration surgery. In the upper right, assisting in a wet lab. Lower left image, former resident and fellow assisting in a wet lab. And here in the lower right, somebody who was a med student and now one of our residents assisting in the wet lab. So certainly, there's a lot of roles for the residents and fellows during the patient screening. They're usually the one at the computer typing things into Excel. Younger folks tend to type much more quickly than I do. So it's very, very helpful to have them when we're doing patient screening in the operating room. They tend to know the surgeries already, so they can assist me, grab instruments, supplies needed during surgery, as well as really play an integral role in the wet lab. So I really enjoy having trainees come with me, and I think they really make the efficacy of the skills transfer courses greater. It is, as I mentioned earlier, essential, though, if you want to get involved in global ophthalmology, especially in the area of keratoplasty skills transfer, to say this is going to take a fair amount of time and effort to achieve the goals that I want to achieve. To build these relationships with colleagues globally. We have, this is a screenshot from our foundation's website. Again, the number of skills transfer courses now is closer to 70. Visited probably about 34 different hospitals now. And you can see just a few of these, and I invite you to visit our website if you're interested. Just take two countries, for example, India. I have been to India 17 times. Majority of these was when I was introducing the Boston keraprosthesis to colleagues at various eye hospitals, as you see listed there across India. The goal of all of this, of course, is to make yourself not needed. And so once our colleagues at these hospitals started doing the Boston keraprosthesis, I really wasn't needed that much anymore. I still was just in India last month, just after Thailand, went to India, and still get questions about patient candidacy and managing post-op complications, which is great, but there's really not a need for me to go to India and teach K-Pro courses anymore. And so that's what I want. I want to be put out of a job. Vietnam, 18 times I've been to Vietnam, to these two eye hospitals in Hanoi and Ho Chi Minh City. And you can imagine being there that many times that you really develop strong relationships, personal relationships with your colleagues there. And so many of these patients, many of these doctors there are not just colleagues, but they really, truly are friends of mine. So let's finish with a discussion about how do you evaluate outcomes of international keratoplasty skills transfer courses. It depends on, you can use a number of different endpoints. One would be the number of surgeons that you train, and that's a good number to use. It's relevant. The number of keratoplasties that those surgeons are performing, as well as the outcomes. And I think that's probably, for me, the most important. But if you're going to look at outcomes, you're going to evaluate that by comparing it to something. And the question is, what do you compare it to? The outcomes of other experienced surgeons in that country or that region, or the outcomes that you may have at your hospital. And you can use different metrics, but I think you do need to be looking at outcomes and think ahead of time, how are we going to assess these outcomes? This is a SurveyMonkey survey that we sent out to surgeons who had attended one of these. It's about 10 or so DSEC courses that we conducted for different countries in Asia over about a 5-year period, and asked them, which course did you attend? Which part of the course did you participate in? Was it the lecture, the wet lab, the live surgery, proctored surgery, et cetera? And here you can see the results. Most everybody participated in the lecture, observed surgery. A little over half participated in the wet lab, but proctored surgery was a much smaller number. And then we asked, what's the most important factor that limits the number of DSEC procedures that you currently perform? And this survey was sent out at least 1 year after the most recent course. And unfortunately, as you see from this histogram, the most important factor that limits number of transplants is just availability of corneal tissue. Insufficient training, though, is the second most common if you group these two together. And so there's still a great need for training our colleagues who want to learn keratoplasty, how to perform corneal transplantation. We have also looked at a number of outcomes, one of which is with the Boston keratoplasties is 3 of the articles that we've published on international outcomes of the Boston keratoplasties. And in these, we've compared the outcomes of surgeons internationally with those here at UCLA. So that's the benchmark that we used, is the local outcomes with the Boston keratoplasties. So in addition to those 3 articles, we've also published a number of other articles looking at indications for and outcomes of keratoplasty in Vietnam, global corneal blindness editorial, a review of cause of corneal blindness and different approaches to addressing it. The article I mentioned earlier about corneal blindness in Asia, and then 2 more recent articles that are not published yet, but they've been written. This is a PhD thesis on outcomes of corneal transplantation at Ho Chi Minh City Eye Hospital, and this one on that sterile irradiated cornea that I mentioned that's being used to salvage globes that were previously being eviscerated for patients with corneal perforation due to infectious keratitis. So I guess partly because I'm in academics, I feel like the best way to critically evaluate your outcomes is to analyze the data as you would for a peer review article and then publish it, because it's going to go through a peer review process. All of that makes you think, okay, this data is valid. And I think, at least for me, makes me convinced that what we're doing is achieving more good than harm, because that is not always the case. I have seen, unfortunately, numerous patients in numerous countries who had surgery done by a surgeon from the US where there was not adequate follow-up. The transplant failed, and the patient ended up worse off than they were before the surgery. And unfortunately, a good number of these patients are children, so they've developed amblyopia because of the failed graft. So even with good intentions, we can end up doing more harm than good. So I think it's critical to have that follow-up on outcomes to make sure that we are achieving the goals that we hope to achieve. So in summary, in developing a sustainable, impactful international keratoplasty skills transfer course requires a number of things. First is the knowledge of the incidence, causes, and management of corneal blindness in a particular region. Got to know where to work. Continuous source of financial support. If you have a fundraiser, if somebody gives you a certain amount of money one time, but there's no ongoing source of support, your programs are probably not going to be sustainable. development of long-term relationships with local surgeons. If you're going to want to go back to Vietnam 18 times, you've got to be wanted to come back. Otherwise, it's just not possible. And if you're going to go back that many times, to ensure that you're building each time on what was done the prior trip, you want to be comfortable, of course, that you feel like you're welcome there and that you're not too much of an imposition. Developing and following an effective skills transfer model. I'd suggest you can start with a model like I've shown you, or follow one that's used by organizations such as Orbis. And depending on what you're doing and where you are, you'll adapt that model to what works. But again, I think it's a process that should remain in evolution during the entire time that you're involved in global ophthalmology. And then finally, it is critically important to evaluate your outcomes. I showed you that Google Drive. Those spreadsheets are updated frequently. I look at those. I'm always looking at, the 1 month, 3 month, 6 month outcomes of patients we've operated on. I'm usually back to Vietnam around 6 months after a prior course, so we can reoperate on anybody who needs to have additional surgery. Or I make sure that corneas are sent to Vietnam for them to do the surgery for a patient, let's say, with a defect that continues to detach, who ends up needing a PK. I want to acknowledge my colleagues on the board of Visionaries International, Roberta Pineda, who's at Mass Eye and Ear in Boston, Sophie Deng, my colleague here at Stein Institute here in LA, and good friend Samar Basak in Kolkata, India. Also like to acknowledge all our industry sponsors, especially Eversight, for providing corneal tissue for us, providing person power, encouragement, inspiration, connections, etc. Without these industry sponsors, none of this would be possible. And I want to thank all of you very much for listening to this talk.
Thank you so much, Dr. Odave. It's really great to hear your experience. You have a lot of it. And I hope everyone on the call learned something and feels motivated to go out into the world and do something impactful. It doesn't look like we have any questions so far, but I'm never shy to ask a question or two while people throw stuff into the chat. I guess, a question that I get asked a lot by colleague surgeons here in the US is kind of, I want to get involved in international work and I don't know where to start. Is there, I guess it's kind of a difficult question to ask you to boil all of this very systematic data-based information that you've presented here tonight into kind of like a simple one place to start. But if you had kind of one place to start and someone asked you that question, like, where do I just get started in international work? What would you say?
Well, that's a good question. Really, I'd have to say I'd want to know more about what they're interested in. If they're looking at prevention programs, I would then direct them to the literature and say, why don't you just put in PubMed, corneal scarring prevention, trachoma, keywords that would show you who's doing work in this field. It happens, to know that Sheila West, for example, at I think Wilmer, and the folks at Proctor do a lot of work with trachoma. And the people at Proctor do a lot of work in Nepal and in India, and are working in Africa as well. So I would direct somebody who's interested in prevention programs to an academic center where colleagues are doing that sort of work. If somebody's interested in surgical intervention to address corneal blindness, and they didn't know who to go to, I would probably say an organization such as the Himalayan Cataract Project, Orbis, etc., would be a good place to start. Even though, for example, I think Orbis says you have to be out of training for at least 5 years to be considered for a volunteer faculty. At least they can direct you to who are the volunteer faculty, and they give you a name and you can contact them. There is a reception at the American Academy of Ophthalmology meeting every year of different NGOs that are involved in addressing global corneal, or global blindness, I should say, not just cornea. And so if somebody wanted to just say what organizations are involved in that space, that would be one thing they could do, would be attend that reception and just introduce themselves and say, here's what I'm interested in. Are there any opportunities for me?
Thank you. Yeah, I know that's a very difficult question to answer because there's so much need, 5 million people. We do have one question that just popped into the chat. Is there any role for virtual or distance learning programs to advance corneal transplantation?
Yes. And Eversight, as you know, has conducted DMAC, virtual DMAC wet labs with domestic cornea fellows, shipping them the instruments and the corneas they need, and then having a camera affixed to the microscope where they're operating, and then an assigned mentor that could be anywhere, watching what they're doing and giving it recommendations and advice. And that, I think, is quite good when you have a good microscope with an assistant head and you have no language barriers, et cetera, and you have what you would expect in an operating room as far as other supplies, resources you might need. In a resource-limited setting, as you're often in, if you're, let's say, somewhere in rural Nepal, that would not work as well because many of these microscopes there where I go, there's no assistant heads. So that makes it hard for me to teach because there's no assistant to look through. The view may not be so good. There's not the ability to grab, a Sinsky or something if you need that for something because these instruments may not be available. So it's a little harder to do that virtual setup for teaching in some countries. But as far as lectures ahead of time to save time on the ground so that when you're somewhere, you can actually devote more of your time to being in the operating room, I certainly think there's a big role for a virtual component there. As far as follow-up after a course, let's say, to discuss patients and issues that arise, I think that the virtual platforms are really great for that as well. As far as, again, going back to the wet lab and teaching surgical steps virtually, that also does depend on the skill level of the surgeon. If somebody has not done any form of keratoplasty or hasn't done it in many, many years, a little harder for you to tell them how to hold instruments, et cetera, if you can't see their hands through the microscope. If somebody's experienced in DSAC and they're transitioning to DMAC, and you're just looking at how they're manipulating the graph when it's in the eye, that lends itself better to a virtual instruction model.
Yes, I think the virtual setting can be very effective. We learned that during
During
COVID.
Yeah.
It can be effective, but it presents a unique set of challenges compared to doing things in person.
Good question. There was a question about how long did it take to organize a 501c3 foundation. I have to confess, my mother is an attorney, helped with that. She has established a couple of 501c3s, but I think it's one of the things you could either do it yourself and you could learn it as you go. And I'm sure there's probably programs now like TurboTax, but for creating a 501c3 that can streamline the process, or you could just probably hire an attorney to do it for you, but that's going to cost some. But I don't think it would cost that much because I don't think it's too onerous. One key about 501c3s, it's a publicly supported nonprofit foundation. So you have to show public support, meaning you can't have one person who's funding a 501c3. That does not show public support. So you want to have a bunch of donors, even if it's small amounts. How do you do that? Easy things. We do, for March Madness, we do a bracket sponsored by Vision International. So everybody pays $10, makes a $10 donation to Vision International, and then they're in the bracket. We've done like a Halloween benefit where you pay $10 to get in. These are things where you can get dozens of people giving small donations to your organization that you can show to the IRS to say, here's evidence that we have broad public support, instead of, again, one person supporting it, which could put your status in jeopardy. There are reports that are due each year to the IRS with a 501c3. Usually if your income is below, I think it's like $25,000 or $50,000, it's fairly simple to do the filing. If you get to be bigger, then it gets more complicated, but that's great. If it gets bigger, that means you have money to hire people to take care of that. So I wish that we were bigger than we are, but we're big enough. All of the donations, for example, for our organization goes directly to buying corneas, instruments, training people to prepare tissue for EK, for example. None of it goes to support the travel of the surgeons. Everybody pays out of their pocket. And I think that's the best way to do it. So there's sort of no misperception about what that money is going to. It all goes directly to our activities.
And there's a couple other thank yous for a great presentation in the chat. And I have one more quick question. We have like 3 minutes left. We might as well use it all since we're here. I noticed, I was looking at the participants here, and I noticed several eye bankers from different eye banks all over the country that are on the call. So I'll ask a question for them and us. What ways can eye banks get involved in global work besides just simply providing tissue, more with the theme of the talk, which is sort of teach a man to fish?
Right. Several ways come to mind immediately. One is we have had several people who were eye bankers who came with us to teach EK preparation. It's really great to take preloaded, pre-stained, pre-stamped DMAC tissue with you and then do that. But if the surgeons locally don't have access to prepared DMAC tissue, it doesn't mean it's going to be sustained. So having somebody with you, an eye banker who's involved in tissue prep, who can identify 1 or 2 people at the local hospital, usually junior physicians, and teach them how to prepare tissue either manually or with a microkeratome for DSEC or strip tissue for DMAC surgery is critically important for us to really have any impact when we're talking about training in EK. Another way that an eye banker could get involved as far as hands-on would be to help with eye bank capacity development. In a number of countries we go, there is an eye bank, but it's usually fledgling. The one in Hanoi, for example, they recover maybe, I don't want to misquote, 100 corneas per year. They're looking about, how to increase the number of corneas recovery. So any advice an eye banker could give regarding counseling, approach, tissue evaluation, processing, distribution, best practices, even just agreeing to say, we'll share our SOPs from our eye bank with you, would be incredibly useful. And there are a number of eye banks, as you know, who have had an international arm. SightLife comes to mind, obviously, where they've helped eye banks, especially in India, convert from their recovery system where it was either home-based or at a funeral home to a hospital-based recovery program that has really changed the game as far as the number of corneas being recovered in lots of areas of India. And I'd like to see that replicated in other countries. And the only way that's going to happen is involvement of US eye banks who can lend their expertise to these other eye banks to help them grow and increase their capacity.
Yeah, thank you. We did get one more question. We're very close to out of time. Do you have 1 minute?
Of course.
So learning keratoplasty is hard, the question begins, involving both intraoperative and postoperative complications. Do you help international colleagues as a consultant during those complications? Because at times it can be discouraging for first-time surgeons.
Certainly. Yeah, I'm looking at the question here. So during these complications, well, obviously during surgery, yes, because I'm sitting there. So I'm not going anywhere until that surgery is done. Postoperatively, yeah, you have to. You can't abandon your colleagues and give them if you operate on, let's say, 12, 15 patients, or sometimes we've done up to 20 in a 1-week course. They're going to be inundated with all these post-op patients, and you have to be there for them and have to be able to respond in a quick manner. I find a lot of people like to use WhatsApp, which is not my favorite app to use for corresponding, but everybody uses it, so I do that. I prefer to use our Google Docs, where they'll put up pictures and I'll take a look at that. But we've also progress to where we're doing more Zoom-based conferences, at specified time periods, let's say a week, a month, 3 months after going somewhere, to follow up on these patients. But in regards to the question, a lot of times you can't wait. If a complication occurs, you see a rejection, looks like a rejection at 6 weeks. You don't want to wait till the 3-month Zoom call. You got to talk about it then. So you need to make yourself available after each one of those courses, especially that first 3 months after a course, to manage all of these issues. If you don't, you're doing a disservice to your colleagues, a disservice to those patients, and you're probably not going to be welcomed back to that hospital. If you do, if you are available for them and you do help, and especially if you can help provide tissue if it's needed for cases that have failed and need to have repeat keratoplasty, that truly would be a sign to your colleagues there that you are committed to help them. And again, that will entice them to want you to come back and continue to work with them.
Thank you for taking the time to answer that last question. And we are 2 minutes over, so great webinar, very great topic. Thank you everyone who stayed. Thank you so much, Dr. Levy, for sharing all this information with us. There is going to be, as everyone logs off of the webinar, there's going to be a quick survey. It's like 2 questions. Please fill it out. Let us know what you thought. And any final parting words, Dr. Levy?
No, I just appreciate everybody's attending. And if anybody's interested, has questions, please feel free to contact me. My email, I think, was on the last slide, but if you don't have it, it's Aldave, ALDAVE, at jsei.ucla.edu. And if you just need connection, advice, whatever, I'm happy to help any way I can.
Thank you. All right, I think that's it. Thank you to everyone who joined, and have a good evening.
Bye-bye.
Bye.